If everybody could find their seats, please. Okay, great. So our 2 o'clock program starts with novel therapies in epilepsy, exploring alternative treatment options, including promises and problems facing gene therapy, IVIG, steroids, CBD, and other pharmacological therapies that are on the horizon. Our moderator is Scott Demarest, MD. On the panel today, in order of appearance, Elia Pestana night, talking about IVIG and steroids. Eric Marsh, Ph.D. MD, trial experience. And Tim Benke, gene therapy. Scott?
That was great. You did my introduction for me. That's wonderful. So that's them. I'm going to introduce a really quick concept that I want people to sort of track as we talk about these various things that are coming down the pipeline, just so we're all on the same page. And that is the difference between epilepsy treatment and disease modification. So an epilepsy treatment, honestly, it's a Band-Aid. You take it, your seizures reduce in number, severity, frequency, whatever it might be. You take it away, seizures come back. That's traditional anti-seizure medications. That may improve some other things, because if you're having less seizures, that's a good thing probably, and it may improve the function and other symptoms. But it's different than disease-modifying therapy. This is something where we're saying, can we change the course of a disease? Can we change overall outcomes, not just epilepsy? So now we're talking about, can we improve, sure, seizures, but also sleep, development, GI, vision, motor, pulmonary, language, list goes on for CDD. And so our speakers hopefully will also be able to sort of speak to that element. And any particular treatment, are we talking about more one side of things or the other? And with that, we'll have Elia.
Hi, everybody. I am Elia Pestana Knight, and I want to thank the organizing committee for putting this wonderful conference together. And I also want to thank them for inviting me to talk about novel therapies. But as you realize, I'm going to be talking about very old therapies. If you remember the progression and the development on anti-epileptic drugs or anti-seizure drugs that Dr. Kessler shows earlier, you are going to notice that steroids were initially associated with the treatment of epilepsy in 1964 when the ACTH was discovered. It was a best therapy for infantile spasms. And then in the 1970s, mid-1970s, the IVIG started being used as a drug for the treatment of Lennox-Gastaut syndrome, which is an umbrella under which there are many different etiologies. It was initially used, the IVIG for Lennox-Gastaut. And both treatments, the underlying idea is that they both produce some modulation of the immune system and the inflammation that is associated with severe seizure, although the truth is that 50 years later, we still don't understand how that works. So already, Scott mentioned some of the points that I want to mention with this talk, and is these medications are part of the treatment, alternative treatment, palliative treatment. These medications are not meant to cure the CDKL5 disease. And as we progress, we're going to see a little bit more about what is the indication and when I use this medication in these cases. So it may make sense to think outside the box when we are talking about CDKL5, because we know that the medications that we have do a very, very poor job controlling the seizures, and this has been very well documented. This is a study that includes patients from the United States and Europe, and these are the traditional anti-epileptic or anti-seizure medications, and you can see that they all have a very low efficacy. But on top of that, they all have a loss of efficacy over time. So the drug that right now is working, 12 months later may not work at all. So this is a problem. And this is a problem that is not only inherent to the CDKL5 disorders, it's also seen in other epileptic encephalopathies or other genetic causes. So as I mentioned before, the goal of the treatment, these two treatments, is reduce the severity and intensity of the seizure. But what seizures? So the seizures that are always present are the motor seizures. And this is what I tell my families we are talking about. Motor seizures are referred to seizures in which a motor symptom may lead to a prolonged seizure or may lead to falls causing injuries. So these are the seizures that we do not want. Other seizure types like accent seizures, staring, minor partial seizures are typically not sensitive to this treatment. So the goal of this treatment is not to eliminate those. And of course, we go to these treatments when the traditional medications are not working because these medications have their own set of side effects. So the take home is these two medications are not a cure, and they are part of what we call palliative treatment. It helps, it eases the disease, but it doesn't resolve the problem. So let's start with the steroids. How we got to the idea of using steroids in patients? Well, we know that many patients that have CDKL5 fall under the umbrella of Lennox-Gastaut. And when I refer to Lennox-Gastaut, I am referring to the combination of seizures, the different seizure types, and the combination of the EEG findings, both of them. That's how this syndrome was initially defined as an electroclinical syndrome. And we also know that for this umbrella diagnosis, Lennox-Gastaut, the corticosteroids, the hormonal treatment, and the steroids have been beneficial. If we look at what is recommended for the treatment for Lennox-Gastaut, that said, because of randomized trial, because of the expert opinions, etc., we can see a list of medications that are common to the initial list that I show you, and a lot of these medications do not work or do not work completely for children who have CDKL5. So what we know about the steroids, the different variation of steroids, and the Lennox-Gastaut syndrome in particular. Well, so seizures get better after 6 weeks of treatment, right? ACTH seems to be, which is an injection, seems to be better than oral steroids for the treatment of Lennox-Gastaut syndrome, okay? But here is one of the problems. There is a relapse rate of 40 to 50% when you stop the medication. And these are medications that you cannot keep for a long time, although in pediatrics, some diseases require long treatment with steroids because of the systemic side effects. What diseases we are talking about? Very close to home. For the pediatric neurologist, Duchenne dystrophy is a disease that affects the muscles, that affects the children's ability to walk. So these patients have to go sometimes years of treatment with steroids, and there are consequences. Children who have a chronic kidney disease, some of them has also to go in treatment for steroids for many, many, many years. So it's possible to do this, but the consequences of the side effects are really, really serious and should be considered. Also, we know that the steroids have been used for status epilepticus in patients with Lennox-Gastaut, and this is a work of Charlotte Dravet, who also described the Dravet syndrome years after. So if you look at the new literature, doses as 1 milligram per kilo can produce seizure freedom in patients with Lennox-Gastaut, but there is some patients become seizure free and some patients only achieve a seizure reduction with these medications. There is additional literature also, and there are many medications that are under the umbrella of steroids that we use. ACTH, methylprednisolone. There have been comparisons between ketogenic diet and corticosteroids for the treatment of epileptic encephalopathy. At 6 months, 14% responders. And also for PCDH19, there is documented an initial response to the seizure, but then when you stop the treatment, again, the seizure relapse. How about the IVIG? Again, the IVIG have been used for Lennox-Gastaut, and there is plenty of literature. We don't know how it works for CDKL5. Because if you look at the list that I'm going to show you, a summary of the publications of this medication for patients who had Lennox-Gastaut, at the time that these publications happened, we didn't know anything about the CDKL5 gene, right? So we don't know what patients are. So thinking with that idea in mind, and looking at this study from Canada of IVIG for refractory epilepsy, I want to bring your attention that there was one patient with diagnosis, Rett syndrome, okay? There are plenty of patients that don't have diagnosis. Some of them may have CDKL5. So what was their outcome? So they studied 27 patients, and 22 of those patients have some degree of seizure control. That was 50% of seizure reduction, 75% seizure reduction, 90% seizure reduction, or seizure-free. And any of those outcomes are very good outcomes for when we talk about epilepsy. Now, what happened with the child with Rett syndrome? Because it's a sister or cousin disease of CDKL5. Well, this patient has a 75% seizure reduction after 37 months of treatment. There are some problems with the treatment with IVIG, and the number one is you have to be near an infusion center because you have to come every month to get the infusion. There are few places that they use IVIG in which they have figured out how to do the home treatment, but this is not what is happening to our patients yet. It's very expensive, so getting the insurance to approve it is an ordeal. We figured out a way around, and as part of our team, we have a rheumatologist. And when we work with Dr. Seth, we can navigate the waters of prescribing the IVIG and doing the treatment. Now, this is the table that I was referring to. As you look at the number of publications, we are starting here in 1979, and we are ended up, I think it's 2003. I cannot see well from here. So during those periods, we didn't know anything about CDKL5. So maybe some patients that were treated there have this diagnosis. There is the most detail of this study is trying to figure out how IVIG helps and if there is any change in the immune response of the body, which is another issue that we don't understand well in general for epilepsy and in particular for children in CDKL5. They studied 13 patients, and they found a 50% reduction in 4 patients, 25 to 50 in 3 patients. They could not, since we are talking about biomarkers here, find a relationship between the seizure reduction and having a better EEG. Okay, so this is something to keep in mind. And the reason that I want to bring this to attention is not all the anti-seizure medications that we have, even though they can suppress seizures, not all of them will suppress the spikes on the EEG. So we have to be careful with this when we outline what are our outcome measurements. Right? See, if we have a medication that will not suppress the spikes, you cannot use the EEG as your outcome measurement. They look into other things. For instance, they look at immunological parameters, and they found that they were abnormal in some kids. They look at specific markers of inflammation in the brain. Oligoclonal bands is a marker of inflammation. Unfortunately, LP is not a feasible study to study the CSF in these patients. They did find difference in the interleukin in the brain and the plasma of these patients. So maybe these are biomarkers that we should at least discuss and think about whether they are useful. So how we put these two medications together? This is not a specific protocol for CDKL5. This is the way that I go with a patient with epileptic encephalopathy who is having a lot of motor seizures, prolonged motor seizures, multiple motor seizures with fall, and there is not any other alternative treatment. So we start prednisone. I documented everything with EEG. I like EEGs. I trust EEG. We do an immune evaluation with Dr. Seft. And then we start the prednisone 2 milligrams per kilo, and that is for a month. And depending on the response at a month, we proceed, weaning the dose slowly, or if there is no response, we wean the dose quickly, okay? Now, our experience from treating epileptic encephalopathy is that there is a group of patients that you treat them with steroids, they respond, you eliminate the medication, the seizure relax, then you have to give them another course. And what we always hope in these cases is that when we add the IVIG at some point on top of the treatment of steroids, we got an effect that is prolonged over time. Does it make sense? Okay, so on month number 2, we start the IVIG. Now, how often can we accomplish that? You're gonna see. This is the dose that we use, 1 to 4 milligrams per kilo, depending on the age and weight of the patient, okay? When I use the IVIG, it's a patient that I know he has been a responder to steroids before. If I don't have that information, we try. But if the patient is not a responder, I have not encountered a single patient that didn't respond to steroids that it did respond to IVIG. Not for CDKL5, for all the patients that I have treated over the years, okay? We are almost done. 2 minutes, you said? Yes, okay, so I probably will have some less overtime. I want to show you some cases. This is one case, and I am highlighting here his ML. The phenotype that he has spasms with exarrhythmia. You know that there are patients who have spasms but do not have exarrhythmia. And he has focal seizures, and this is the mutation that he has. So let me orient you into this map, our graph. Here we have prednisone doses over time, okay? And here we have IVIG doses, okay? So up to 8 doses. Here we have, this is what I measured in clinic, seizure types, okay? MD is multiple per day, D is daily. Spasms, hypomotor seizures, hypermotor seizures, and other partial seizures. The EEG with exarrhythmia. What is happening with the development in the 4 main areas, gross motor, fine motor, language, and socialization, okay? And any adverse reaction. This is very basic schedule. And what happens after a month of treatment with steroids? No spasms, no hypomotor, no hypermotor seizures, no partial seizures, only the accent seizure persisted, and as I told you, they don't go away with this treatment. And over time, that equation remains, you see, until the end of the treatment. Let me show you the EEG. There are some improvements in the development. You can see here from walking to climbing to jumping, okay? And there are adverse events. So mainly hypertension with a higher dose of the steroid. This EEG is the EEG at time 0 before the treatment with steroid was initiated. This EEG is the EEG at 18 days of the treatment with steroids. Now the patient has a posterior dominant rhythm. There are still some spikes, you can see them here. And there are some spikes that are more diffuse and generalized, but overall this is a EEG that looks much better than the initial one, right? So this is the protocol that we use with this patient, because this patient is the best responder we have with CDKL5 and IVIG treatment. So we initially gave an IVIG steroid, 7 months. We got a break. We got an EEG that I'm going to show you. Seizure relapsed some months later. And then we started on IVIG alone because of the adverse events to steroids. And he has been on IVIG for 17 months now. No motor seizures, some accent seizures, some partial seizures, no side effect, and met all the goals of his IEP at school. So I think this is our successful story. This is the EEG during that break period where he was not on steroids or IVIG. And of course, there are some periods of multifocal spike emergence. These are other patients that we have treated with a similar protocol. They have a different phenotype. And I'm gonna stop here with our team. I see some familiar faces here, so you know who they are already. And I let Scott to continue with his presentation.
All right, Eric's going to go next. Really quickly, Amanda is going to tell you how you can submit questions through the app. so that your questions can start coming in as these talks are going on, and we'll address as many of them as we can after all 3 of their talks.
If you guys go to the dialogue section of your app, you should find a place that says Novel Therapies, and you can submit questions there while they're talking. You're also welcome to wait, and we'll have a microphone passed around at the end. They will be able to see your questions. They won't know who put them in, so there's your chance to get your anonymous questions in.
Good afternoon. Thank the organizers for inviting me and all of you attending. And I'm going to just spend the next few minutes going over some novel therapies, the first of which is also a very old therapy. Cannabis has been around for a while. And a little change, I'm actually from the Children's Hospital of Philadelphia, not from the Children's Hospital of Colorado. I think Dr. Demarest was recruiting me. And I was asked to come give this talk because I've been involved in a bunch of clinical trials. So I've been had some grants and gotten funds to do studies of a variety of clinical trials in these early onset epilepsies. So just there's a point of, I assume everyone here, or I don't know if everyone here is aware, that Greenwich Bioscience or GW Pharma's product Epidiolex was just approved by the FDA this past Monday for Dravet and Lennox-Gastaut. And as we know, that many children with CDKL5 can fit into the electroclinical diagnosis of Lennox-Gastaut. So that's going to become a product that is available for use in this population sometime in the near future as they get through all the remaining regulatory issues. 3 months, Dr. Demarest is saying. I will believe that when I see it. Minimum, there you go. So, but there needs some clarification here. So what is Epidiolex? What is cannabis? So being in Colorado, I probably don't have to say much about cannabis. You guys all probably have a lot more experience than I do with that in the state of Colorado. But cannabis is a plant that's been around for a very long time. And cannabis has at least 489 identifiable chemical constituents. And the component of it, the class of chemicals in it that makes it fairly unique, is it has this class of compounds called cannabinoids. And the cannabinoids, for which there's at least 70, some people say there's over 100 cannabinoids in the cannabis plant, are thought to give the plant some of its potential medical uses. Now, THC, which is the cannabinoid that is in highest concentration in many plants that are bred for street use, for recreational use, is the cannabinoid, it's tetrahydrocannabidiol, is the cannabinoid that gives the plant the high. And it works by acting on the brain's endogenous system where it has receptors to something called the endocannabinoids, and that alters brain activity and gives the high that does it. Now, CBD is the second most prevalent cannabinoid in the plant, and in plants that are high in THC, it's often low in CBD, and plants that are high in CBD often are very low in THC. And hemp, which is marijuana without the THC, is a plant that's very high in CBD. So CBD has no psychoactive effects. How CBD works in the brain is actually still an area of research. There's a number of hypotheses about how CBD potentially works in the brain, but no one really knows the answer to that. And it probably works in multiple mechanisms throughout the brain, which gives it its potential anti-epileptic effects. How, for the other possible effects of CBD, antispasticity, anxiety, or of cannabis, how much CBD or THC you need is not known. And studies are needed to try to figure out really what are the full benefits of medicinal marijuana, and are there really full benefits, or are there very limited benefits of this plant? So one of the issues that comes up when you talk to families, now that Epidiolex will be available, so Epidiolex is a highly purified version of cannabidiol from the plant that is essentially 99% cannabidiol with 1% other cannabinoids and aspects in it. And so one question that families ask is, well, don't you need some THC? Because out there in social media it says, well, you need a little THC, you need a little bit of this, a little bit of that. And the answer is, we don't know. And, you know, it's possible some people do respond with a little bit of this or a little bit of that, but what we do know is Epidiolex, or a very purified CBD, and that's important because it's real data that we can move forward on. And one of the good things about CBD is very high doses are tolerated. It's not psychoactive. It's tolerated very well. And, you know, it seems like it's a very safe molecule for long-term use of it. So the CBD, or Epidiolex, and a synthetic CBD from Zynerba Pharma has actually now gone through the gold standard of clinical trials, as Dr. Kessler told you earlier today, which are placebo-controlled clinical trials. And so GW Pharma, which is Greenwich Biosciences in the United States, has completed 4 phase 3 studies of purified CBD in 2 groups of intractable pediatric epilepsy patients. This is Dravet and LGS. And 3 of those have been published in high-profile journals, 2 in the New England Journal of Medicine, 1 in Lancet. The last is going to be published shortly. And there's also a study about its interaction with other drugs, which I'll get into in a second. And Zynerba did a transdermal, it's a patch preparation, which they only presented their data as a poster, but it was for adults with intractable focal epilepsy, and they actually did not meet their primary endpoint. So there's an example where CBD might not work for something, or at least going through the skin, it might not work for something. This is just the cover page from the study from the Lancet, which was the first published Lennox-Gastaut cannabidiol study. And this is the study protocol that was followed. 200 patients entered it, 171 got randomized to placebo or to drug, and the results of which basically showed that there was a statistically significant reduction in seizures, in drop seizures. So the primary endpoint in the study was drop seizures. So these are seizures that would cause the patient to fall, or would cause the patient to fall. So if they were lying down, you think they would fall, that counted. And there was a very significant difference between placebo and Epidiolex. This data is looking at percent reduction in seizures, and if you can compare the doesn't work. Doesn't work. There it is. Can you see my arrow? No, you can't see my arrow. That there is, as you get to further reductions, 75% reduction, 24% of the cannabidiol patients had a 75% reduction, but only 8% of placebo, and 6% of the cannabidiol patients were seizure-free. And when you talk about patients with very intractable epilepsy, to obtain seizure freedom, typically your neurologist will say less than 5%, less than 2% on your 3rd medication. 6% is, I'm not sure if it's statistically different than that number, but it is bigger than that number we typically quote people. And then on the bottom is the global impression of change. So this isn't just talking about seizures, as Dr. Demarest was talking about at the beginning. You know, are there other improvements that people see? And this is just a very simple questionnaire. You know, is your child improved, much improved, not improved, worse? And when you look at that, placebo versus CBD, there's a real shift to the right, where CBD, more patients, more families whose children were on CBD reported that they had a bigger improvement, to suggest that there is potentially other possible effects, but that really needs to be studied more carefully. Side effects. So cannabidiol has side effects. Many of the patients had side effects, the most common ones being diarrhea and sleepiness. And so it is, even though it comes from a plant, it is still, like any other antiepileptic drug, it has potential side effects that have to be considered and managed appropriately. This is from a poster that was presented this past year at the American Epilepsy Society, where if you follow these patients out for 96 weeks, there seems to be persistent reduction in seizure burden in these patients. So suggesting that there might be a good long-term effect of Epidiolex in these Lennox-Gastaut patients. And one of the issues that comes up is that CBD interacts with the body's natural system to metabolize drugs, and particular types of drugs, particularly clobazam or Onfi, and valproic acid so that you can have interactions of these drugs. So if you're going to start any cannabis preparation, you have to be really careful to know what you're on and let your physician know what you're on so that they can monitor these interactions, because these interactions could be potentially dangerous. So if you looked at patients on CBD who are also on clobazam, you had a better response on clobazam than not on clobazam. And the same is true with valproic acid or Depakote. So there is some interactions. These might be very positive interactions. You know, it's not just that it's the pushing up the clobazam level. There could be some positive interactions that are occurring between here, and more study is needed to figure out what these interactions are and how to make best use of these potential interactions. And this just shows you that as you increase CBD, that the clobazam and the norclobazam, which is the metabolite of clobazam, fluctuate and particularly go up. So there is a real interaction that needs to be monitored here. So that's just a brief overview of the CBD story. And so cannabis is a plant that has a variety of cannabinoids. Cannabidiol is one that seems to definitely have real effect in treatment of seizures, and the Greenwich Biosciences product will be available this fall. And it was an interesting study. Right here you have a drug that has been around for history. People have talked about its use for seizures throughout history. That went from that to families getting hold of it in California and Colorado and reporting on its efficacy, going to getting it into patients using expanded access programs, to finally phase 3 trials that prove that there is efficacy in this condition. And when I got into this, I actually thought we were going to prove that it didn't have efficacy. I was wrong, which is a good thing. But we still need more information. We need more information about the role and this interaction, the other potential positive effects of cannabidiol, and then the long-term data. So now with going over steroids, IVIG, and CBD, we've gone over 3 new but very old in some ways medications. So now I'm just going to take a second to talk about 2 novel therapies, 2 new therapies that are going to be coming to clinical trial or potentially coming to clinical trial in the CDD population. So ganalaxone, you've already heard about this earlier today. You know that it is a drug that augments the activity. It's called a positive allosteric modulator of GABA A receptors, and it should increase inhibition and reduce excitability, which you would hope would decrease seizures in the brain. There's good exposure data to both adults and children, and it seems to be very well tolerated and safe. And there's been some studies that show potential effects. So it is a good drug to move forward in a potential clinical trial in this population. And then the other drug that I'm going to mention, which will be potentially coming for a clinical trial near you, is TAC-935 from Ovid Pharmaceuticals. This is a novel compound that has a unique mechanism of action. It works by inhibiting an enzyme in the brain that alters the effect of a particular cholesterol. It alters this enzyme, which inhibits a cholesterol which can then bind to NMDA receptors. NMDA receptors are one of the excitatory receptors in the brain, and by binding to this receptor, it modulates the activity. By blocking this enzyme, you decrease the amount of this cholesterol moiety in the brain, which then alters the way the NMDA receptor is modulated and would reduce excitability in this way. So it is a secondary allosteric modulator of the NMDA receptor, so its end result would be also decreasing inhibition. It would be decreasing excitability in the brain. So why choose CDKL5 for this? Well, so there is some data from the mice. So as you guys are all probably aware, there's a couple of mouse models of CDKL5 deficiency disorder that are out there. And as you all also might be aware, that the mice actually don't have spontaneous seizures. They don't seize on their own. So a number of different labs have been working hard on trying to see if there's seizure susceptibility. And this Japanese lab, Akuda et al., have shown that if you give NMDA, so these are these excitatory receptors in the brain, so if you give the actual compound NMDA into the mice start to seize. And mice with mutations in CDKL5 seize much more than mice without mutations in CDKL5, saying that these CDKL5 mutant mice are more susceptible to seizures. And if you give at the same time with the NMDA, or before you give the NMDA, if you give this Ovid Pharmaceuticals drug, you block that increased seizures, suggesting that there is a real potential role here in CDKL5. So with that, the company's thinking about moving forward. So with that, I'm going to end and be happy to talk about, in the questions, these clinical trials and experiences in clinical trials as well. Thank you.
Hi, my name is Tim Benke. You heard me earlier today. I'm medical director for the Rett Clinic here at Children's Colorado. So this is a question that comes in the clinic. Dude, where's my gene therapy? So I want to talk about what gene therapy could look like and some other issues. I do have to say that I do need to make some disclosures. I am a consultant for Avexis, which you'll hear about during the talk, as well as Marinus as well. So I think those are relevant disclosures. So let's talk about types of gene therapy. We're going to talk about what the issues are with each of these and the strategies. So one would be what is often called gene replacement, and I'll tell you about what that means. And the other is gene editing. And I'm not going to talk about this, but we can talk about it more. And I see that one of the questions came through was about drugs that interact with glycogen synthase kinase 3 beta or GSK3 beta, so we can talk about that in the questions. But we could also talk about other things like protein replacement or gene read-through. So gene replacement. So there's a lot of excitement with regards to this. And this started with findings in animal models. So in a very artificial situation in the Rett mouse model, where the gene responsible for Rett syndrome, MECP2, was turned off, but then artificially turned back on, it was very exciting that this approach suggests that this Rett syndrome is reversible at the genetic level. This then led to gene replacement in the mouse model using a virus, and we'll talk about that, to add the MECP2 gene back in. That looked very exciting. Meanwhile, a lot of these gene replacement strategies were going on in a lot of other diseases, and this included the mouse model for spinal muscular atrophy. And that was very exciting, and that was then translated into humans. And there's been dramatic responses in spinal muscular atrophy. Spinal muscular atrophy, as you may or may not know, in the most severe form, these children are unfortunately passed by the time that they're 2 years of age. So it's very a severe disease, and with gene therapy, the results have been nothing sort of miraculous, and that not only are the children alive, but they're able to sit and walk. So it's been very exciting. So gene replacement. So what are the issues and questions that we all need to be asking? So it's an addition of a new copy of the gene. It's not replacement. It's not taking away the copy that doesn't work and putting back in one that actually works. So it's addition of a new copy. So replacement is really not exactly accurate. So one of the questions we have to ask is CDKL5 deficiency disorder, what you might call a Goldilocks disease. That is, not too much, not too little, but really you just have to get the just right amount. We know that Rett is a Goldilocks disease because there's such a thing as MECP2 duplication disorder. We're not so sure that that exists with CDKL5 or not. And so we need to ask the question, how do we get this just right and not necessarily overshoot it? We want to ask, can we get it into as many cells as possible, how to prevent an immune response, and how to prevent other side effects. So, gene replacement. How do you do this? You use something these days called adeno-associated virus, or AAV. It's the viral vector of choice. So the viral vector is used as the taxi to deliver the gene. Now, if you use the taxi analogy, you have to be aware that there's only so many people that you can safely put into your taxi, okay? Otherwise, it might tip over. So that's going to be the same thing is true with your viral vector. So the virus is re-engineered to deliver the gene of choice. It doesn't make more virus. The virus is replication incompetent, as they say. And the viral vector needs to cross the blood-brain barrier. The viral vector, it's like the taxi. The virus can only hold so much. There's a limit to the size of the gene. So with AAV9, so that means there's 8 before it and there's going to be several after it. There already are. It can only hold 4.8 kilobases is the biggest gene that you can put in there. The CDKL5 gene is around 3.8 kilobases. MECP2 is around 3.6 kilobases. For spinal muscular atrophy, it's only a wee 1.5 kilobases. But for SCN1A, which is the gene for Dravet syndrome, it's probably too big. It's 12.5 kilobases. So, but the other thing that you have to stuff in there is probably the most important. It's the promoter region. It's that region in addition to the 3.8 kilobases that regulates how well you're going to make your gene be expressed. And so in a lot of these instances, what you put into that promoter is going to be proprietary. The companies aren't going to tell you necessarily what that is. And when it comes down to it, we really don't know what the promoter regions are and which are the regions that are really important. And that's going to be hugely important because you've got to ensure, the Goldilocks issue. You want it to self-regulate and only make enough. So, as I said, this is in addition to the gene. It limits how much you can actually put into the viral vector. So AAV9, it's good. It crosses the blood-brain barrier. We don't know if the future versions are going to have less immunogenicity. And basically, you're putting a virus, it's something foreign into the body. Is the body going to react to it? So the questions are this. What if you give it intravenous versus intrathecal with a spinal tap? Well, if you give it intravenous, you're likely to have an immune response. And the issue with that is that you probably might be a one-shot deal. Because if you give it again, the body's just going to get rid of it before it did what it needed to do. But intrathecal, that's a spinal tap that is more invasive. So how many cells in the body do you need to infect with the virus to have a meaningful change? It may be that only 10 to 25% infection is the best that you can get with AAV9. We're really not sure what the numbers are with this, certainly in humans versus animals. So, like I said, the immune response, this may be a one-shot opportunity, such that repeat dosing may not be a possibility. And we need to be aware that when you put in a new copy of this gene, it's inserting randomly. What if you accidentally insert it into a crucial gene? And what if that crucial gene is linked to cell growth? So it potentially could be cancer-causing. So clinical trials. So in spinal muscular atrophy, there's an ongoing phase 2 trial. Phase 1 was very promising. Cystic fibrosis, a phase 1 has been completed. I couldn't find what the results are. And there is a planned phase 1 trial in Rett syndrome, and Avexis has a press release about that. There have been other trials as well that have been various phase 1 phases. What is gene editing? So what are the issues and questions? So this is where we get into that CRISPR-Cas9 question. So it edits a specific genetic change. CRISPR-Cas9, why is there a 9 there? Because 9 is the latest version. Why? Because it cannot yet do all the different possible changes that you would want to edit away. And so that's why they're currently working on versions like 12 and 13 already. So how does it work? It basically cuts and reassembles the DNA at that particular site. And the problem is it does not always completely clean up its mess. And as a result, you have about 25% maximum efficiency, depending on who you read, using this technique. So if you get the right stuff into the cell, 25% of the time, it makes the right sort of change that you want. And how does that make that right sort of change? It's using something called a guide RNA, okay? And that guide RNA is tailor-made to the specific patient change. So you got to make it as close as possible, because if it's not perfect, you can get off-target changes. So your guide RNA, it might recognize your particular change in CDKL5, but that sequence might also be present in another gene somewhere else. The problem is both of these together are too big to put into AAV9. So you'd have to have one virus that had your CRISPR-Cas and your other virus that had your guide RNA. So therefore, we're back to those same issues associated with gene replacement, but it's kind of multiplied by 2. So what are some general unknowns? The cost is unknown. Spinraza is an antisense oligonucleotide therapy that's used for spinal muscular atrophy, and it's very expensive. It's $450,000 a year for the first year and about $350,000 a year thereafter for life. That's another example. But in talking offline to my hematology colleagues about what they think gene therapy is going to cost, the costs are astounding. We're talking several nice big houses kind of cost. So the long-term consequences of this therapy are unknown, and we don't know if there's a critical window or opportunity of treatment. In other words, do you have to treat early or not? And we don't know the answer to that. So we're going to take questions, I think, now. Right. Okay. So Scott has all the questions that have come up.
Can we use one for that? All right, so Elia first. Mostly because I'm just kind of going in order here. There were several questions about IVIG and steroids. How do you know whether or not a patient is going to be a good candidate for IVIG and steroids?
Okay, so in pediatric epilepsy, there are specific indications for steroids. Okay, so steroids or ACTH hormone is an indication, is one of the two best treatments for the treatment of infantile spasms, right? We know that doesn't work very well for the CDKL5 kids. Some kids respond, some kids have partial response, some kids respond and then relax, some patients don't respond at all. So the response to that is very variable, but that's one indication. So if the patient is diagnosed with the infantile spasm phenotype, that's one of the treatments that can be considered. There are other types of epilepsy that we see in the school-age children, like the electrographic status epilepticus sleep. Also, steroids an indication for the treatment for that. Now, in the case of CDKL5, they say the child doesn't have infantile spasm, so it doesn't qualify for the indication, right? So you use the other medications that are indicated, and the way that we do the treatment is not as much as what type of syndrome or umbrella the patient has. For some medications you need that, but what type of seizures the patient has, okay? And if you have exhausted those group of treatments, like often happen for children who have CDKL5, then you have to go to your alternative treatments, oral steroids, IV infusion. IV stands for intravenous infusion of steroids. There are specific names. Methylprednisolone, Solomedrol is another one that you have listened to. Still, there is a choice, the ACTH, the injections, okay? In the older kids, I shy away from the injection because you have to do it for a long period of time. So you have the alternative of using oral steroids. There is a liquid formulation. There are pills that you can give by mouth. And as I mentioned before, at what point I will go to this kind of treatment? Well, if the recommended therapies are not working and the patient is having motor seizures, epileptic spasms, clusters of epileptic spasms, tonic seizures, tonic-clonic seizures, long motor seizures with multiple phases. Sometimes you get tonic and then hypermotor, and then they go back to clonic. All those variations of the seizures that last 15 minutes and they are happening multiple times per week, seizures that you intervene with your rescue medication, clonazepam, rectal diazepam, etc., and you have a hard time making them stop, or they keep repeating multiple times a week. Those are the indications for for steroids. Now, somebody asked what IVIG meant, and I should have said that before when I start talking. So IV is intravenous, and IG stands for immunoglobulin. And the immunoglobulin is natural, so that's how our body defends against viruses and bacteria that come to attack the body. And that's what we try to accomplish when we do vaccines, right? Because if you give the vaccine, you give the virus, whether dead, alive, attenuated, or a part or a piece of the virus, and you expect that the body, our own body, produce immunoglobulins, okay, that will, next time that you get exposed to the real virus, it can attack it and defend it from us. It's something that goes through the breast milk when mothers are breastfeeding. That's why you hear the pediatrician, babies that breastfeed are very healthy, because the memory that protein have in the body of the mother is passed into the baby. So it's a good thing, but it's a very expensive thing to produce. And there are occasions in which the patient could be allergic to certain proteins. This is a protein. Because it's a protein, it cannot be given by mouth, because otherwise our stomach will digest it. So you have to give it intravenous.
So I think there was one other question about whether or not in someone who's older or is well controlled, does it make sense to try any of these therapies? And I'll just say personally that I think that's all about what are your goals of care, what are the risks associated with any particular treatment option, and it has to be a discussion with your provider about whether or not that's going to make sense. You have to realize that things can make things worse also, right? I mean, so sometimes families elect that if it's not broke, don't fix it. Sometimes they say, well, things are pretty good, but I want them to be better, and that's an individual decision. I'm going to get Eric to talk a little bit here about...
Right. So there's one question that was, will Epidiolex be available outside of the United States? Greenwich Biosciences, GW, did this study in Europe as well. They are going through the European regulatory agency now, so they do hope that it will be available in Europe and throughout the world as they get their approvals in other countries in the European Union.
And in the GW study, did you see a reduction in other seizures other than drop seizures?
So for the LGS study, the primary endpoint was drop seizures, but all different seizure types were counted, and there were statistically significant reductions in all the different seizure types. So yes, it's not just drop seizures, though that was the primary endpoint of the study. And in the Gervais studies, the primary endpoint was just motor seizures, were called countable motor seizures, and that was statistically significant, as were all total seizures. So if you include myoclonic seizures or absence seizures, that also had a statistically significant reduction. So it seems to be a broad spectrum anti-seizure medication working on multiple different seizure types.
And I'd be curious to hear your response to this one. Given that in our COE data for Centers of Excellence, we actually have probably 15 to 20% of our CDKL5 patients that are actually classified as LGS. So with that context, how relevant is the LGS and Gervais data to our population?
Right. So, it's a good question, and the answer really is, is the electroclinical syndrome important, or is the underlying etiology, the CDKL5 deficiency, what's more important in getting a response? And I think many people would say that for a drug like cannabidiol that has probably multiple mechanisms of action is somehow affecting various aspects of the abnormal network that's generating epilepsy, that it would be etiology independent. And prior to these phase 3 clinical trials, there was this large expanded access program in multiple sites around the country. There's over 500 patients in it now, in which there are a decent number of CDKL5 patients. I know they are writing up that data on CDKL5. I do not know the exact results, but in looking at the patients at my site who are on it, it seems to be similar to the general Epidiolex data as well. So which is what drives it, the CDKL5 or the LGS? I don't think we have an answer to that. In this case, it seems like there might be a similar response, but that's something we'll learn, in patients with CDKL5 who have an electroclinical diagnosis of LGS. We will learn with time whether it is efficacious or not.
And one more question before we put Dr. Benke on the hot seat. For TAC 935, and I apologize, there's another typo in my open slide, and I think I got the numbers wrong. But have children been treated with this, and what does that look like in safety?
Right. So there's been exposure of TAC 935 in a variety of different conditions. I don't know all the details of that, so I will, I think there's an Ovid table, yes. So there's Asif Parker, Dr. Asif Parker is from Ovid, so he could potentially answer that question, or someone can find him afterwards and answer the question.
Miriam is signaling me that I think we're close to being out of time. Is there?
We're close to being out of time. I'm going to throw a couple things at you, and you're going to answer them as quick as possible.
Yes.
So the first is, if it's gene therapy and you fix the problem, why would there be continued cost? Are we going to actually have a trial in CDKL5 for gene therapy? And should it be as effective for different groups, boys versus girls? And then finally, you're going to slip in there something about exon activation and whether or not we're going to have a therapy to control exon activation. Go. 30 seconds.
So the cost is there would be a single cost for the single dose. And Spinraza was a monthly type thing. That's the way it was set up. It was always meant to be monthly. But again, for a single dose, they're estimating that the cost could be into the six figures.
And will that single dose maintain the right amount of expression continuously for the life of that individual? I think
we don't know.
Is not something we have a great answer for still.
Right. So the next question was...
When are we going to have a gene therapy trial for CDKL5?
I think that what we would like to know is, does this work in the mouse model or one of the other rodent models to reverse some of the symptoms in that model as first proof of principle? What would need to then happen is the same thing that's happening for Rett, is that there would need to then be an expansion into to make sure that this is safe in monkeys, non-human primates, before you actually went forward. And those are not things that I'm making up, but it's how the FDA views how these sorts of things need to be moved forward. Next question, quick, 10 seconds. I would think that probably the first trials, I think that's up for discussion as to whether or not it would be boys and girls. But for Rett, when it's going to start with the phase 1 trial, it's going to be all young girls with classic Rett type syndrome. So it may be something similar for CDKL5. It may just be girls, but I think that's too early to say. It'd be nice if it was more broad than that, but we'll see.
What is exon activation? Can you control it?
Exon activation means that in all of the cells in your body, half of them are, you have two X chromosomes. If you're a girl, if you're a boy, you have an X and a Y. If you're a girl, one of those X's is turned off, the other one is turned on. And so the question is what if you could just have it skewed so that the X that had the correct copy of CDKL5 was the one that was turned on? Can you switch that? And I think that there's a lot of studies that are looking into how to selectively skew exon activation, but there's still a lot of research in animal models and cell-based systems that needs to happen before that moves forward.
Sorry if I didn't get to everybody's questions, but we'll be around and you're welcome to come and grab us. Thank you.